All right. Well, how do you see these patients, Jan? How do they show up in your office?
Well, I have a pretty biased referral pattern in terms of mine are mostly from the ER. I mean, directly from the ER. They'll get admitted because they're usually part of, they have other injuries at the same time, some at a level one institution. So, sometimes they do get sent from, an outside ER urgent care. And, these are ones that, if they come with this splint or a boot, I always ask them if there was any, one of the things I always ask is, did they have to put your ankle back into place?
Hmm.
Because if someone had a dislocation event, I'm more careful about removing their splint because I don't want them to redislocate in the office, but I do confirm always with new x-rays that they're still located. I think this is
Yeah.
one thing. So if a patient's from out of, they injured themselves out of state, they come to my office. If they said, oh no, they had to put my ankle back into place, I'm definitely checking to make sure their ankle's still in place. Because I've seen that sometimes where they've lost their reduction and the
Yep.
patient has no idea because they're taking
Yep.
pain medication. We have the adrenaline flowing. So, I would say those are the kind of type of ways that patients are usually, coming to my office, but mostly from the ER.
Yeah. I have a little different practice. I see them more as outpatients, and so that probably means that my bias is to less severe injuries, I guess, if that makes sense. So maybe more of these kind of more subtle injuries, but certainly can see more high energy as well.
Mm.
But I think the point being that they can come through in a multiple different ways, right? You can
Right.
sometimes see them in the office and sometimes see them coming through the ER in that case. And I think you bring up some really good points in terms of the clinical assessment because, as you were talking about, understanding what the mechanism of the injury was, how did they have to manage that at their initial stop if you didn't see them in the ER? There's a lot of things we focus on, and if you're seeing them in the ER situation, that's a little bit different, because you're looking at soft tissue injury as well with that, and making sure that like degree of swelling, open injuries, things like that. I think are going to be driving the decision making a lot more than
Yeah.
just like where do they hurt kind of thing. But if you see them in the office, understanding the mechanism, understanding where do they hurt, I think can be really helpful, especially as we talk about a little bit later, assessing for other injuries or stability. And you brought this up earlier, but I think thinking about examining the foot, examining the proximal fibula up by the knee, especially in an isolated injury, is really super important because you need to know if they have pain, if they have a proximal fibula fracture associated with things. And then I don't really get too much in the syndesmotic test for an ankle fracture, I guess. It's just so hard to know. I don't know if you do any special testing. I mean, it's one thing if a patient comes in with no fracture and a syndesmosis injury, that's a different animal than that has a fracture that you need to fix.
100% agree. If a person could tell if they had a syndesmotic injury, I think that would be amazing right now.
Yeah.
It's difficult to tell sometimes in the OR.
Yes.
And imagine how you would tell clinically
Yeah.
for the subtle ones. I mean,
Yeah.
obviously, if there's like the eponym, the log splitter injury where the
Yep.
talus between
Yep.
the tibia and fibula, then you know for sure. But
Yep.
otherwise, I think it's a good guess.
Yes, that's right. Some things to kind of mention, when it comes to the X-ray evaluation, standard views are going to be 3-view ankle X-ray for these. But then, we'll talk a little bit more about this here in a second. But, one of the things we're looking for is that medial clear space and really determining whether or not the ankle injury is a unstable ankle injury. And so we're kind of always evaluate for what we call medial clear space widening. Certainly you can see it initially on some views, and that's pretty clear. But a lot of times it does require doing stress views to help drive the decision making. So, question for you, Jan: what's your way of determining stability on when you stress them?
Yeah, so I've gone back and forth a little bit. My big thing now is trying to have them do not gravity stress, but actually weight bearing stress.
Mm-hmm.
But even if I talk to the patient beforehand and instruct them, like, I'll ask them like, okay, how much weight did you actually put on it? Right.
Yep.
I remember you work with Dr. Torchia as well as I did during residency. And what he used to do, which I thought was great, was a single stance weight bearing view. And
Hmm.
then you know the patient has to stand on it, right?
Yeah.
It's
Yep.
because and you know I've gone to gravity. I don't do a external rotation test, so I do gravity stress
Yep.
or a weight bearing test, and I think weight bearing stress. So I go back and forth between the two because I think it also depends. There's a lot of factors involved here, maybe age of the patient, their other risk factors. Are they amendable to non-operative treatment in
Yep.
terms of can they wear protect themselves? Are
Yep.
they neuropathic? I think there's a lot of other factors. It's not as just simple as, hey, do a gravity stress or weight bearing
Yep.
test.
Yeah, it is. It's more subtle. And the other thing is like how the details around the injury. Meaning, like sometimes when I come in, I'm like, well, could you walk on it afterwards? And sometimes they'll say, yeah, I walked on it for 2 days, and then I went in and got it looked at. And that to me probably, in somebody that's not neuropathic, would indicate stability.
Yes,
Especially if I'm on the fence. If you're like, oh, is that a little bit positive, or is that, that's a millimeter one way or the other? That just helps me feel confident that it's probably somebody I can continue to treat non-surgically.
agree.
All right. So these are the views. We kind of talked about these already. The medial, the lateral malleolus. On the lateral view, you want to look for the posterior malleolus. And so I bring these up here because these are normal imaging. You got to get used to looking at normal imaging. Anything you would add to this, Jan?
I think one of the key things is knowing whether the patient's weight bearing or not.
Mm-hmm.
I think that can be very helpful because I think that changes our view both of the ankle and many joints, right? Ankle, foot, and knee can all change. So that can be very useful knowledge. And sometimes they'll put like, our X-ray techs will put they have a little like gravity, looks like a quarter almost with like
Mm-hmm.
three metal small balls in them. And
Mm-hmm.
if they're down towards the bottom, that means the patient's weight bearing. Otherwise, they're not. So
Yep.
I think that can be helpful information to know when evaluating these patients.
Yeah. Yeah, I think that's a great point. The view is so much better when they're weight bearing too. I mean, there does something to it that you can see the articular surface so much better, and the mortise is a bit more clear, and everything is a little bit more straightforward. So here's a 3-view ankle, Jan. This is a patient that came in after a trip and fall or twisting her ankle and has pain on the lateral side of the fibula. And what you'll notice is there is an irregularity here. I try to draw on here. There's an irregularity, on the fibula right here, and you kind of see that on the 2 views on your mortise and your AP. Really don't see too much here on the lateral view. So what do you think? Surgery?
It'd be interesting if we posted this online, what the answer would be. But it's like an experiment. I would say no. You do see that like Weber A fracture, right? And I have operated on this before. I have not done it acutely, but where they've developed a painful non-union
Yeah.
very occasionally. Like it's
Yep.
maybe one or two, three, something like that. And I see a lot
Yep.
of fractures like you do.
Yeah.
And they already have some arthritic changes. If you look at the medial malleolus, you can see a small like osteophyte there. So
Yep.
on the talar dome, on the lateral view, you can also see some impingement. And so, yeah, this is a non-op.
Yeah.
Hey, here's a boot maybe. If it's bothering
Yep.
you a lot, let's get you moving and walking and kind of
Yep.
see what happens.
Yeah. I totally agree. This is a non-operative case, and I guess my question, maybe follow up to that, is, and you kind of alluded to this already, but is what are you telling this patient? You put them in a cast, you put them in a boot. It sounds like you put them in a boot or a brace or something. This is
Yeah.
pretty stable. I think that's the point. Like, it's a very
Yeah.
stable injury. You can kind of get on it and be pretty active pretty quickly.